attack of the fast susceptible anemia during pregnancy.
In these sessions, I would like to request Dr. Radhakrishnan to discuss detail about the ECG evaluation of congenital cyanotic heart disease. Sir, please.
Thank you. This topic or this subject is going to make sense only if you have been listening to the previous topic, that is clinical evaluation of cyanotic congenital heart disease, because a lot of them are linked to each other. You don't look at an ECG before examining a patient or clinically evaluating a patient. You always do that before. So when you actually look at an ECG, you should have a lot of prior information about the patient as to what the child is suffering from. And as I was discussing with you, what group of lesions it is it decreased pulmonary blood flow, it is increased pulmonary blood flow. So ECG in isolation has really no sense, and I'll come to that later. One of the very great minds of pediatric cardiology, Alexander Nadus, had way back in the 70s or 60s or 70s commented that ECG, accurate physical examination, and radiology forms the tripod on which rests the clinical diagnosis in pediatric cardiology. Omission of, unfamiliarity with, or misinterpretation of any of these three tools spells disaster. You might not, or we might not agree with this anymore, especially with the availability of imaging technology, because a lot of our clinical pitfalls which we have, whether it is ECG, X-ray or clinical examination, has actually been taken away by the availability of imaging technology. This was at a time when X-ray was the only imaging technology that was available, but again, it just shows you how ECG and accurate physical examination, especially when a physician or somebody is sitting in the periphery who might not have access to imaging technology, is so important statement that he had made. Remember that ECG rarely reflects the anatomy of the lesion, but it reflects the physiological derangements due to the lesion. For example, if an ECG shows left ventricular hypertrophy, it shows the physiological problems. The cause can be anything. It can be aortic stenosis, it can be hypertension, it can be subaortic stenosis, it could be hypertrophic cardiomyopathy. So you cannot diagnose the anatomy by looking at the ECG, but you can predict the physiology by looking at the ECG. Therefore, in the setting of cyanotic congenital heart disease, do not attempt to diagnose the anatomy based on ECG alone. For example, do not look at an ECG and say this is tetralogy, because even transposition with VST-PS will have the same ECG as tetralogy. So either you should have prior information about the patient by clinical examination, or you should say that this patient has an ECG which is consistent with, say, right ventricular hypertrophy and right axis deviation. Probable anatomical lesion can be made by looking at the clinical ECG and X-ray findings. I mean, you can look at an X-ray and say, look, this is most likely a tetralogy by clinical examination, X-ray and ECG. But there are some exceptions of ECG diagnosis. Arrhythmias, electrolyte imbalances, etc. are always diagnosed by ECG. whether it is in the setting of cyanotic congenital heart disease or otherwise, because for diagnosis of arrhythmias and electrolyte imbalances, you cannot, even if you have the most sophisticated of imaging like CT, MRI or echocardiography, you have to have this basic investigation like ECG to diagnose. Of course, there are some classical ECGs where when you look at it, you know the diagnosis, but these are, remember, extremely rare. That you look at an ECG and say, oh, this is this particular diagnosis. But they are extremely rare. On a day-to-day practice, you very rarely encounter them. Also remember that normal values and changes that occur with age. Remember that here we are not dealing with a full-grown or an adult or an adolescent, but we are dealing with a child who could be a newborn, an infant, a child, and therefore there are normal variations, because as the child or a newborn grows into childhood and adolescence, there are certain variations which occur with age. So one has to remember this. You should also remember the definition of right ventricular and left ventricular and atrial enlargement, because if you don't know, you cannot diagnose. You should know how to calculate QRS axis. There are no shortcuts to this, and this is something which comes only out of practice. You look at an ECG daily, and in all patients try to diagnose the axis or try to calculate the axis. Only then, when it comes to a difficult case scenario, you will be able to pick it up. You should be able to differentiate between pressure and volume overloading, etc. So these are some certain basic things which you have to know before you try to interpret an ECG in the setting of cyanotic heart disease. Now, if you look at this, 3 ECGs which I have shown you, it's a normal infant, and if you don't know the age of this child, you will say that this patient has right axis deviation and right ventricular hypertrophy. But for this child it is normal. But if it is an adult, then it is very abnormal. And that is what I meant by the normal variations, which you should understand. If you look at the left hand corner at the bottom, you will see that the axis has already started changing. This is a normal child. It is still probably a bit right axis deviation, but you can gradually see that the left ventricular forces have started appearing. So again, looking at this ECG and interpreting it as such has no meaning at all. And then you come to this slide at the right hand corner, which is a normal adolescent, and you see that now it looks like an ECG of a normal adult person, wherein there is normal axis, that is between 0 to 60 or whatever you consider normal, and there is no right ventricular forces. So the reason why I have kept these 3 slides is that interpreting an ECG without clinical information is meaningless. So the crucial data that you need to know is the age. You should need to know whether this patient is cyanotic or acyanotic, which will be known only in clinical examination. You should know what the heart size is, which will be known only by the X-ray and sometimes by clinical examination. So again, we follow that same classification which we follow for any congenital heart disease. Decreased pulmonary blood flow, increased pulmonary blood flow, cyanotic, acyanotic. So the same classification we keep on following. In the cyanotic blood group, which I am specifically want to discuss, you have patients with pulmonary stenosis, no VSD, pulmonary stenosis with VSD, which is tetralogy physiology. We have patients with increased pulmonary blood flow. We have patients with high PA pressures with decreased pulmonary blood flow, that is the Eisenmenger physiology, pulmonary venous obstruction. Then we have patients with pulmonary pressure normal and no PS, that one group which I am discussing about the AV fistula and left SVC to LA. The cyanotic patients with decreased pulmonary blood flow, commonly they have a ventricular septal defect. In them, the right to left shunt is at the atrial level. And then we have these patients with Epstein's anomaly who have normal right ventricular systolic pressure. Here is a typical X-ray of these group of patients. Right axis deviation and right ventricular hypertrophy. Now I am coming to the classification. What are the types of ECG that you would be able to see in these group of patients? As I briefly discussed in clinical evaluation, basically you can have 4 types of ECGs in these patients, of cyanotic patients with decreased pulmonary blood flow. Remember that we are dealing with decreased pulmonary blood flow now. Right axis deviation, right ventricular hypertrophy, right axis deviation, left ventricular hypertrophy, left axis deviation, left ventricular hypertrophy, and left axis deviation, right ventricular hypertrophy. So it is very easy to remember these charts, and with each of them you have some of the causes. The most common cause of right axis deviation and right ventricular hypertrophy is tetralogy of Fallot. But you can also have patients with double outlet right ventricle, transposition of great vessel, can all have the same type of ECG. The most common cause of right axis deviation with left ventricular hypertrophy are in patients who have a small right ventricle. And a typical example of these patients is pulmonary atresia with a small left ventricle without ventricular septal defect. Then we have patients with left axis deviation with left ventricular hypertrophy. The classic example is tricuspid atresia, and left axis deviation with right ventricular hypertrophy is AV canal defect, that is endocardial cushion defect. What you also notice is that right axis deviation LVH, LAD LVH, LAD RVH, in all these patients single ventricle comes as a cause. So single ventricle ECG, it is typically said that can mimic any type of ECG, whether it is RAD LVH, LAD LVH or LAD RVH. So single ventricle always becomes an important diagnosis in these patients. An example of tetralogy physiology, as I showed you, RAD and right ventricular forces. It can be seen in transposition, in double outlet, all of them having VSD with pulmonary stenosis. A very important feature, it is said, of tetralogy of Fallot, that you also always should take the right-sided chest leads, because if you look at V1 in this patient, it does not show the classical feature of right ventricular hypertrophy, which means that the transition has already occurred. So if you do not pick up the right-sided chest leads, you might say that there is no right ventricular hypertrophy in this patient. So you should always also take the right-sided chest leads in these group of patients who are cyanotic. But you can clearly see that there is right axis deviation in this patient. Here is an example of a patient, again with right axis deviation and right ventricular forces. This time, this patient on echocardiography had double outlet right ventricle with pulmonary stenosis. But remember that looking at the ECG, you cannot diagnose double outlet right ventricle. So both these ECGs look similar. An example of a patient with transposition of great vessels with VSTPS. Again, right axis deviation and right ventricular hypertrophy. Again, you cannot differentiate by ECG whether it is tetralogy or transposition. There are certain points which help us to differentiate, which I am not going into detail, but in the majority of patients, the ECG pattern looks similar. Right axis deviation, right ventricular hypertrophy. So it is impossible to differentiate between these three group of patients unless you have prior information or subsequent information on imaging. This is a typical X-ray of tricuspid atresia. Left axis deviation and left ventricular forces. You can see that there are no R waves in V1. It is an RS pattern in V1, and V6 shows a QR pattern, as if this is a normal ECG. So if somebody gives you this ECG without telling you a diagnosis, you will say that this ECG is normal, almost normal, except for some left axis deviation, which can be present as a normal variation. So again emphasizing the fact that looking at an ECG without clinical data has really no meaning at all. But in the setting of cyanotic patient, this is so abnormal that there can be only one diagnosis, the most common being tricuspid atresia. Of course, as I said, single ventricle can mimic all these echo, but basically tricuspid atresia is also a form of single ventricle where the right ventricle has not developed at all. Here is an example of a left axis deviation with right ventricular forces. You can see that the axis is left-sided, it has a counterclockwise loop, and you can see right ventricular forces predominating. V1 shows a tall R wave, V6 shows deep S waves. This is typical of a patient most commonly of endocardial cushion defect, but as I emphasized, it can also occur in single ventricle. Remember that it is very difficult to remember all this in one lecture. It is very important for you to go back again and look at that chart, and then things become very easy. A patient who has right axis deviation and left ventricular forces. What you saw before that was a patient with left axis deviation with left ventricular forces. Here you are looking at a patient with right axis deviation with left ventricular forces. This is typically seen in patients with pulmonary atresia with intact septum where the right ventricle is small. Even in tricuspid atresia the right ventricle is small, but there the axis is left, here the axis is right. And as I told you, you can see this in patients with single ventricle also. A typical example of a patient with single ventricle, an ECG taken from a patient with single ventricle, right axis deviation with left ventricular forces. Here also it was right axis deviation with left ventricular forces, but this patient had pulmonary atresia. But we are not expected you to know this. You cannot diagnose looking at an ECG whether it is pulmonary atresia, intact septum, or whether it is a single ventricle physiology. We don't expect you to know this, but at least you can narrow down your differential diagnosis based on ECG. Another example of a patient with single ventricle. Here it is left axis deviation with right ventricular forces. What you saw there was right axis deviation with left ventricular forces. Here you see left axis deviation with right ventricular forces. Remember that such ECGs can also be seen with endocardial cushion defect. So please do not try to remember them. That chart which I showed you before has been extremely useful. You can always keep that with you and quickly demarcate the differential diagnosis. Then we come to a group of patients who have increased pulmonary blood flow. And if you look at a very strange feature at the top of that line, you will see almost all the patients in that 4 groups has either biventricular hypertrophy or left ventricular hypertrophy, which I showed you before. So the ventricular hypertrophy pattern can be very difficult to differentiate between these 2 groups, because throughout that spectrum most of them will have either biventricular hypertrophy or left ventricular hypertrophy. So it is very difficult to differentiate various groups, but the axis can be different. You can have right axis deviation with BVH or RVH. You can have RVH with RAD with LVH. You can have LAD with LVH. You can have LAD with RVH. And so you have a chart here which you can keep with yourself and remember that what are the possible diagnoses you can have. But as I told you right in the beginning, there is no way to escaping the fact that you should know how to diagnose an axis. You cannot remember that. You have to know that. You cannot have any chart to guide you as to what the axis is. You have to remember that. It comes only out of practice. Also, you should know what the clinical setting is. If you look at this type of physiology, they usually have cardiac enlargement, they have congestive heart failure, they have X-ray enlargement of the heart. So within this subgroup, if you analyze their ECG, you can have a differential diagnosis as pointed out to you. An example of a patient with TAPVC who comes under the group of cyanotic congenital heart disease with increased pulmonary blood flow. The ECG looks like a patient with atrial septal defect, right axis deviation and right ventricular forces. So this ECG has no meaning unless you know the clinical picture of the patient. It could be very well an AST, a simple lesion like AST, or it could be a complex lesions like TAPVC. A patient with TGA VST, DORV VST, truncus arteriosus, all these patients come under the same group of increased pulmonary blood flow with cyanosis, and you can see all of them have the same type of ECG. Right axis deviation and biventricular hypertrophy. Same pattern throughout. And then finally you have patients with Eisenmenger physiology. Predominantly all of them will have right axis deviation and right ventricular hypertrophy. When they have left ventricular hypertrophy, then you should diagnose single ventricle physiology. But the most common cause of Eisenmenger physiology in your day-to-day practice is a patient of VST, PDA and AST. And then probably in the cyanotic group it will be TGA or it will be DORV. Remember that all of them will have the same ECG, right axis deviation and right ventricular hypertrophy. So you should be able to first diagnose the Eisenmenger physiology, and then only you will be able to look at the ECG. Very rarely patients of Eisenmenger physiology can have left ventricular hypertrophy. In all of them, it is usually a complex heart disease where the right ventricle has not developed at all. Tricuspid atresia, single ventricle, all these patients, since they don't have a right ventricle, so per force they will show left ventricular forces. But single ventricle, etc. are very rare diagnosis in clinical day-to-day practice. The most common cause of Eisenmenger physiology leading to cyanosis is VSD, ASD, PDA, and then it comes to the cyanotic group like TGA or DORV or truncus. And if you look at their ECG, uniformly it is only right axis deviation and right ventricular hypertrophy. So to summarize, do not look at ECG for diagnosing structural heart disease in isolation. Rarely you will see classical ECGs. The reason why this ECG was shown is that this is a classical ECG. Also, they don't fall under the group of patients with cyanotic congenital heart disease. This ECG looks as if this newborn baby has had a myocardial infarction. It shows ST elevation, deep T wave inversion. But if you look at this ECG in a patient, a newborn child, this is typical of the lesion called anomalous origin of the left coronary artery from the pulmonary artery. But this is just to deviate from the point to say that very rarely you get so-called classical ECGs. You have to integrate clinical X-ray and ECG finding. Because remember that diametrically opposite physiologies can have similar ECGs. What do I mean by this? A patient of tetralogy of Fallot has decreased pulmonary blood flow, pulmonary stenosis physiology. A patient with Eisenmenger physiology have severe pulmonary hypertension, whereas a patient of tetralogy will have normal pulmonary artery pressure. So these are two diametrically opposite physiology. One is an Eisenmenger, the other is a decreased pulmonary blood flow like tetralogy. And if you look at their ECGs, it will be absolutely the same. It will have right axis deviation and right ventricular hypertrophy. So two diametrically opposite physiologies have absolutely the same ECGs. How do you differentiate them? So unless you have a clinical picture of these patients, it is impossible to diagnose on ECG what they are suffering from. So this is the example I was showing. Tetralogy of Fallot with pulmonary atresia or pulmonary stenosis and Eisenmenger VSD will both have RAD and RVH. But remember that they will have distinct X-ray and clinical findings. So you can differentiate them at that level, but not at the ECG level. VSD and truncus arteriosus have similar ECG. Absolutely different diagnosis. One is a simple straightforward VSD, the other is a complex anatomy like truncus arteriosus. How will you differentiate them? Not by ECG, but by clinical examination. One will be cyanosed, the other will not be cyanosed. By X-ray examination, which will be typical for both, and that is how you differentiate, but not at the ECG level. Thank you very much. I think I'll end my talk here.
Yeah. Thank you very much, Dr. Radhakrishnan. Actually, since we are having time, I would like to request to put some light on our clinical procedures, like all the cyanotic congenital heart disease. What is the time normally they do present? It is the part of our clinical presentation. So it will be nice if, sir, you can just describe little bit the time of presentation, when normally do they come to clinic, and with how much severity and all these things, with very brief.
Remember that the first person who comes in contact with a newborn child is a pediatrician. So the onus is always on the pediatrician in order not to miss important diagnosis which can be fatal. And that is where it is said that two very important information which a pediatrician should always have when the newborn baby leaves the hospital and goes home. One is to feel for the femoral pulse. That is a very important part of clinical examination in order not to miss coarctation of aorta. Second is auscultation. Listen to the baby, see if there are any murmurs. I'll come to the pitfalls of auscultation in a newborn baby. And thirdly, when the baby leaves the hospital, one should take the oxygen saturation. At least one oxygen saturation is very important in order not to miss the patients with cyanotic congenital heart disease. Because even though you might not be able to hear important murmurs, the reason, let me tell you, is a very complex lesion like transposition of great arteries, which can cause death within the first week of life if it is missed, will produce no murmur at all because of the type of physiology that we are dealing with. Even a most complex form of congenital heart disease like transposition will not produce murmur. But definitely, if that baby has an oxygen saturation taken at the time of discharge, it will be severely cyanotic and the oxygen saturation will be in the 50s, 60s and 70s. So obviously, when you have saturations like that, you cannot discharge a baby. As far as murmurs are concerned, remember that when a baby is born, the pulmonary physiology is such that the pulmonary artery pressures are high. So, murmurs might not be very obvious because the pulmonary vascular resistance has not dropped. And there are so many lesions in congenital heart disease where production of a murmur is dependent upon the fall in the pulmonary vascular resistance. For example, VST, which is one of the most common lesion. A large VST, which is likely to kill the child in the first year of life if it is untreated, will not produce any murmur at birth. The reason is that the pulmonary vascular resistance is high, so the VST becomes silent. Both the right ventricle and left ventricular pressures are high. So, I am coming to this point because the baby will always come for the next visit. And it will come for immunization to the pediatrician. It will come for various other reasons. The newborn baby or the infant can come to the pediatrician for visit. And that is where the pediatrician has to be very alert. You should always auscultate the baby and to see that murmurs which do not appear in the newborn period have appeared in the first 3 or 4 weeks of life when the baby comes back for immunization to the pediatrician. So, again emphasizing the role of the pediatrician in order not to miss clinical diagnosis of these patients. Of course, the pediatrician should again look for cyanosis, listen, auscultate again, and if necessary do an ECG and X-ray and subsequently echoes. So these are the ways where congenital heart disease has to be picked up in the newborn period or infancy period so that these patients can be adequately treated. Unfortunately, we still see in our country, developing countries, patients who have never been diagnosed. You see tetralogies at the age of 15, 16. I've just come from my clinic at the hospital, and there was a young man who had come from Afghanistan. I mean, we are all similar, whether it is Afghanistan or India, etc. It's the same pattern of poor diagnosis at early age, poor referral pattern. And here was a 16-year-old patient who was suffering from tetralogy of Fallot. It's remarkable that this patient has spent 16 years of life and has not been diagnosed as tetralogy of Fallot. I'm sure he must have been running, playing games, and all tetralogy of Fallot have to be symptomatic. There are no asymptomatic tetralogy of Fallot. But yet, it has been completely missed. The diagnosis has been missed, and now he is coming to us at the age of 16, 17 for proper treatment. But he has spent the first 16 years of his life suffering. This would never have happened if good screening techniques, good pediatric screening techniques occur at this age. There is another level of screening which occurs, and that is at school-going age. There are some lesions like atrial septal defect, etc., which are very benign lesions which might be missed even in the first 1 or 2 years of life. But when they reach school, a good screening program at the school will not miss these diagnoses, and you will be it is a horror to see patients of atrial septal defect coming to you at the age of 30s and 40s saying that they have never been diagnosed. They have gone to the doctor for multiple reasons, for a common cold, cough, or gynecological reasons, or whatever you may have, and they have never been diagnosed as atrial septal defect for 30, 40 years of life. That again indicates poor screening of patient at various levels of doctor or physician interaction, patient-doctor interaction.
Yeah, I think this information is quite right. Even I also see my first open heart surgery in Ranchi. The patient was around 45 years age, who is having atrial septal defect.
Yes.
And I hope that all of you might be following whatever our sir was telling. So the basic initial stage was very much important, and if your mind is open, if you know the basics things and all these procedures, then probability of missing all this case will be very less. I hope all of you have been very much benefited. Again I am trying to tell you, please don't look the ECG component as a single component, as Dr. Radhakrishnan informed you repeatedly. It has to be in a combination with all other clinical findings along with the age and other things, and you can definitely not going to diagnose the anatomical lesion, rather than you are going to find the physiological process, and ECG will help you to narrow down the differential diagnosis. There are many stages of diagnosis, so ECG is the one of these things. Here I would like to say thanks to Radhakrishnan.